Hello and good evening. I'm Randy Hecht and welcome to the Research to Practice Cases from the Community. I'll be moderating today. These are our faculty members who you can already see up there. I think there they are. Today we have a really distinguished group of people who not only will be talking about the research, but also have been doing a lot of the research. So there's Andrea Cercek down closer to the end, Arvind Dasari, Pashtoon, and of course, Eric van Cutsem. So these are relevant conflicts of interest, which you'll be able to look at. And then Dr. Love will be on virtually, and these are his disclosures. Here is the commercial support for today. The Research to Practice CME Planning Committee staff and reviewers do not have any conflict of interest to disclose. This program will contain discussion of non-approved uses of agents and regimens. Please refer to the official prescribing information for each product for approved indications. In advance of this program, Dr. Love interviewed 9 general medical oncologists who presented cases and posed questions on a number of key clinical issues. Video excerpts from those interviews will be featured throughout the program. This is where we're headed today. Dr. Dasari will begin by discussing ctDNA evaluation in non-metastatic disease. Dr. Cercek will discuss the role of immune checkpoint inhibitors in the management of non-metastatic MSI-High colorectal cancer. Dr. Kasi will cover oligometastatic disease, including hepatic-only metastases and the role of ctDNA evaluation in metastatic disease. I'll talk about immune checkpoint inhibitors in MSI-High metastatic colorectal cancer, and Professor van Cutsem will finish out with other actionable genomic alterations in metastatic colorectal cancer. And Module 1.
All right, thank you very much. It's an honor to be part of this very distinguished panel. As was just mentioned, I'll be talking about ctDNA evaluation in non-metastatic colon cancer. I'll start with a very brief introduction to ctDNA, then quickly summarize the data that we have from observational cohorts, and then spend some time talking about efforts ongoing with prospective trials, as well as discussing strategies for future interventions. Circulating tumor DNA, even in the best of circumstances, constitutes only a small proportion of the entire circulating free DNA. As you can imagine, the amount of ctDNA is proportional to the amount of disease in the body. And even in patients with metastatic spread, the amount of ctDNA is 10% or less. And in patients with minimal residual disease, or MRD, who by definition do not have any radiographic evidence of disease, it's less than 1%. The vast majority of circulating free DNA actually comes from other sources in the body, predominantly from the cell turnover in the bone marrow. So this could lead to potentially false negatives when we're looking for MRD, given the minimal amount of circulating tumor DNA that we may see. And the circulating free DNA from the bone marrow and other sources could contribute to false positives, especially through clonal hematopoiesis during cell turnover in the bone marrow. So an ideal MRD assay should have very high sensitivity in that it's able to pick up MRD. And it should also have very high specificity in that it weeds out the false positives. So that's an ideal assay. And there are a lot of efforts ongoing currently to develop the perfect assay. For the most part, these could be divided into 2 large groups. Firstly, tumor-informed, where the source of truth is the patient's own tumor, so it's personalized. So you're starting off by sequencing the patient's tumor, identifying certain genetic mutations, for now, only mutations, and then designing primers that are then used to test the patient's plasma serially. The advantage is that it's a personalized assay, weeds out the chip mutations, but the downside is that it's a two-step process, at least initially, because you have to sequence the patient's tumor, then develop primers, then look at the plasma. So it may take a little longer than ideal to get the results back, especially in that critical time period when you're trying to make decisions about adjuvant therapy. Tumor-agnostic assays could have large panels looking at not just mutations, but also epigenetic alterations. And you look at the plasma directly, so it's tumor-agnostic. The advantage is that the turnaround time is very quick, but the downside is there's always the concern that we may pick up chip alterations that we don't know whether they're from the tumor or not. There's been exponential increase in the use of MRD assays since the initial approval for colorectal cancer by CMS for coverage in 2020. And this use is rapidly increasing by the day. And reflecting this very strong interest to use it clinically, there's been a lot of research as well with regards to MRD assays. And the initial data all came from observational cohorts, and these are the key takeaways from these cohorts. These are 3 large cohorts, cumulatively over 10,000 patients, using a tumor-informed assay, Signatera. And the first key takeaway is that MRD is very strongly prognostic for recurrence. Patients who are MRD positive, their recurrence risk is very high, with hazard ratios ranging from 10 to 20. And in patients who are MRD negative, recurrence is low, whether they get adjuvant therapy or not postoperatively, with 2-year disease-free survival around 90% with or without adjuvant chemotherapy. On the contrary, in patients who are MRD positive after surgery, when you give them adjuvant therapy, you are improving outcomes, but you're not curing everybody. The 2-year disease-free survival probably improves to around 35 to 40%, so the vast majority are still recurring in spite of adjuvant chemotherapy. So these are the key takeaways from the observational cohorts. And these observations have led to interventional trials to establish clinical utility. And looking at these clinical utility trials, it's helpful to look at them in 2 different time points. First would be immediately after surgery. Currently for colorectal cancer, we have well-established adjuvant therapy options. So these trials are asking the question of whether we could risk stratify to escalate or de-escalate these established adjuvant chemotherapies. And this is building on the very high positive predictive value and the very high specificity of these assays. In patients who finished adjuvant therapy and are undergoing surveillance, we also know that there is a lead time between turning MRD positive and developing radiographic recurrence of several months. And the question is, can we do interventions with novel therapies in this time period and prevent these recurrences from happening, knowing that almost everybody would recur without further therapy? In stage 2 colon cancer, the current approach is that most patients would not get adjuvant chemotherapy. Perhaps only 20 to 25% of stage 2 colon cancer patients actually get adjuvant chemotherapy per standard of care approaches. So a lot of these trials that are ongoing globally, listed here, are asking the question, based on the ctDNA status, can we actually escalate therapy for these patients to improve outcomes? The US or the North American trial was the COBRA trial that was halted after an interim analysis. We do have results from the dynamic trial that were presented a few years ago and also updated subsequently. This trial enrolled stage 2 colon cancer patients after surgery, and they were randomized 2-to-1 to CT-guided management versus standard of care management. And the CT-guided management, the patients who are ctDNA positive received adjuvant chemotherapy, and those who were negative underwent observation. In the standard of care management, as the name implies, they received standard of care therapy. The primary endpoint was relapse-free survival at 2 years. A key secondary endpoint was the proportion receiving adjuvant chemotherapy. And as you know, this trial showed that the proportion of patients receiving adjuvant chemotherapy in the ctDNA-guided arm dropped by about 50%, from about 30% to 15%. But this did not come at a cost of relapse-free survival, and the relapse-free survival rates were comparable between these two arms. In stage 3 colon cancer, the current approach is that almost everybody gets adjuvant chemotherapy. So the ongoing trials globally are asking the question, based on the ctDNA status, can we escalate or de-escalate this therapy to further improve outcomes? In the US, the Circulate US trial is ongoing. And as you all know, the Dynamic 3 trial presented some initial results earlier today from the escalation arm. So far, we've talked about the post-operative state and the ongoing clinical trials in this space. Moving on to the post-adjuvant space, where patients have finished adjuvant therapy, undergoing surveillance, and if they're MRD positive, what we know is that there's a lead time. Depending on which study you look at, it could be as much as 9 months. And can we intervene during this time period to prevent recurrences? The FDA actually supports this approach, and they came out with a guidance document where they suggested that ctDNA indeed could be used as a marker to identify patients for clinical trials in this space. And they further suggest that ctDNA clearance could be potentially used as a marker in early phase trials as a go, no-go decision point. But for more definitive trials, you still need disease-free survival as the endpoint, especially if you're thinking about it from a registration point of view. So I'll point out some of the unique features of this setting. The first thing is that by selecting patients who are the highest risk, you are able to pick up signals which you would otherwise lose in all comers. And these are data from the CALGB 80702 trial. One of the questions that it asked was, what is the utility of adding on celecoxib to adjuvant chemotherapy in patients with stage 3 colon cancer? In all comers, there was no effect. But a subsequent analysis suggested that when you looked at ctDNA positive patients, it did improve outcomes with a hazard ratio of 0.55, which is very impressive. The second takeaway would be using this as a tool to get quick decisions about go, no-go. And these are data from the MSK group that looked at the role of adjuvant immunotherapy in patients who are MSI-High and ctDNA positive during surveillance. These are patients with any solid tumor. And what they found was that by treating patients with immunotherapy in this setting, they were able to potentially cure about 2/3 of these patients, providing compelling data to consider studying this concept further. Now, how would a definitive trial look? Well, because you're enrolling patients who are the highest risk of recurrence and who would have an event of recurrence within 2 years if left untreated, these trials would be very, very efficient. And these are data by Dr. Kasi in a very thoughtful editorial, where he showed that compared to the conventional approach where you're enrolling thousands of patients, by using this approach where you're only enrolling MRD positive patients, you're able to get these trials done with 200 to 300 patients very quickly and more efficiently. And this was demonstrated by the Altair trial, where they asked the question about the activity of TAS-102 in patients who are MRD positive. And this trial was conducted with around 250 patients. Although this trial was negative, it was path-breaking in many ways. So in summary, I think ctDNA is a very powerful tool in the management of colorectal cancer patients. Assays are available today, and they're improving by the day. And we're looking at modulating standard of care adjuvant chemotherapy in the postoperative space. We're also looking at developing novel adjuvant therapies using MRD as an integral biomarker. Thank you very much.
Thank you, Dr. Dasari. So now we have a video.
Good evening, everyone. I'm Neil Love from Research to Practice, and to enhance the clinical relevance of this meeting, over the last few weeks I met in individual Zoom recording sessions with community-based general medical oncologists, Drs. Warren Brenner, Gigi Chen, Stephen Fred Divers, Victoria Giffey, Henna Malik, Shakir Pelez, Priya Rudolph, Eric Rupard, and Syed Zafar to present cases and query the faculty on the stage about their experiences and relevant research findings, beginning with Dr. Brenner, who presents a common scenario in clinical practice.
This is a 70-year-old female who had a T3N1 right-sided colon cancer. She had 1 out of 3 positive lymph nodes, no other high-risk features. We had a long discussion that chemotherapy is considered standard of care for stage 3 disease. And she was very adamant about avoiding chemotherapy at all costs. And we brought up the role of MRD testing, understanding that not really used to make management decisions in stage 3 disease at this time, although there are studies looking at this. But she elected, understanding the lack of data in the setting, that if she was MRD negative, she was going to elect not to receive chemotherapy. She came back MRD negative, and now I've been monitoring her for close to 2 years. She has MRD testing done every 3 months, and she's had no evidence of any recurrent disease. She really was looking to avoid chemotherapy completely. And really, these patients with T3N1 disease, which is quite common in colon cancer, they generally have a pretty good prognosis. And I think it makes a lot of sense. If MRD negative, are they really that different from the 2As that we're kind of doing the same thing? And I don't do it in general without a lot of, extensive counseling. But ultimately, so far, it's worked out well, and we continue to monitor closely. And she understood, the lack of evidence in stage 3 disease at this time. But, so far, it's worked out well.
So these are the questions. Outside of a clinical trial, what is the current role of ctDNA testing in stage 3 colorectal cancer? Would you currently be comfortable de-escalating adjuvant chemotherapy on the basis of negative ctDNA results? What about foregoing adjuvant chemotherapy altogether for a patient who is hesitant to receive it? And then the other question was, which I think will be addressed perhaps later, outside of a clinical trial, what is the current role of ctDNA testing in stage 2 colorectal cancer? Would you currently be comfortable foregoing adjuvant chemotherapy on the basis of negative ctDNA results? What about using a more intensive adjuvant chemotherapy regimen on the basis of positive results? We're fortunate to have two speakers who are world experts in the role of ctDNA in colorectal cancer. So, Dr. Dasari, I'm going to let you get the first crack at it since you just gave the talk, a wonderful talk.
Yeah, Dr. Brenner very nicely summarized the current state of affairs and the unanswered questions. I would say, as of today, while the data are compelling for stage 3 colon cancer, these are from observational cohorts, so we're still awaiting randomized trial data. So we would need to have very detailed conversations with the patients. So single time point assessment with ctDNA sensitivity is estimated to be perhaps around 60% or so. With serial monitoring, probably goes up to around 80 to 85%. Now, would I be comfortable de-escalating or foregoing adjuvant chemotherapy? I would not advocate for it. I would not do it. But if the patient is pushing for it, then perhaps after a very detailed conversations about the pros and cons is what I would is my take on the first question.
Another discussion, another talk that'll be at ASCO is also perhaps changing in the AJCC, staging criteria. And one of the things that wasn't mentioned, one of the differences are tumor deposits and whether or not, and I think that's probably even more important, as we make these decisions. Dr. Kasi, do you have any other thoughts for this stage 3 patient?
Building on what Dr. Dasari just mentioned, where the field of liquid biopsies right now, while it doesn't matter which assay you talk about, whether it's tumor-informed, agnostic, methylation, it's easy to interpret the positive assay. I have a longer discussion and explanation before I even order the test as to what a negative test would mean, because especially in a curative setting, negative could mean two things. One is that you're already cured and maybe you don't need chemo, but the other very likely possibility is that it's low shedding, and even though the test may be 100% sensitive, if the DNA is not getting spilled in the blood, the test is not going to invent the DNA, you know what I mean? So you don't want to miss these curative chances. So I would be very apprehensive about falsely reassuring somebody with a negative result. I think it's as Arvind was mentioning, it's a discussion of the data. The good thing is we have data from thousands of patients now to show it to the patient to make an informed decision. Serial testing can help overcome, but no matter how good an assay becomes, there will be a function of biology and some false negatives, no matter how good assay gets. So it has to be interpreted with clinical picture in mind. So I would not be comfortable in de-escalating, but would bring the data to discussion to the patient.
The one question is that if you noticed the patient was getting every 3-month repeat, and at least in the United States, that is available, and at least for my patients, is generally not charged to the patient, because at the end of the day, it doesn't matter how much it costs, it matters how much the patient ends up having to pay, at least to my patients. It does matter how much it costs. Dr. Van Cutsem, do you ever use this in Belgium? Would you have a patient who would be similar to this?
Well,
outside of a trial.
Outside of trials, it's not approved by EMA because of just the facts what was said, that there is no proof from randomized trials in this situation. However, we have more and more patients who ask for it, and then we can do it case by case, but it's normally not reimbursed by the health authorities because it's not approved. So it's an individual case decision, but not quite often done these days outside of clinical trials because of these reasons.
So would any of the ctDNA experts like to comment before we go on to the next one on how often to do this? Let's say that you're committed to doing this. How often would you check ctDNA without going into one type of ctDNA test versus another?
One thing I just wanted to add on that exact scenario where actually I found ctDNA helpful in actually guiding therapy is, to the person that was just presented by Dr. Brenner, who absolutely would not take chemo, that same person is then calling the office to get chemo yesterday because the test came back positive. So maybe, to reiterate the plan or to reaffirm the plan, I think the assay has been helpful. I think, as Dr. Dasari mentioned, if you look at the dynamic study, the sensitivity goes up if you do 2 time points. You're looking for a needle in the haystack. There's a bigger haystack in the immediate postoperative period, so there's a lot of noise where you can miss a signal. So you at least want to have 2 time points in the first, adjuvant window, which is defined as up to 12 weeks. And then subsequently, I just piggyback it on the standard of care follow-ups outside of evidence and trials.
Okay, well, let's go on to the next video. Do I push, or I think...
The next case, presented by Dr. Pelez, is a 65-year-old woman who was treated with adjuvant chemotherapy for stage 3B colon cancer.
She had a torrid time with FOLFOX. Just you name it, nausea, diarrhea, abdominal discomfort, mucositis, peripheral neuropathy. After cycle 5, she actually developed pretty significant transaminitis. Her creatinine bumped, and even I at that point said, okay, I think you're done. Her Signatera was initially negative. It was repeated a couple months later and a couple months after that, and was negative on all 3 occasions. And then a few months following that, her Signatera became positive. We did CT imaging and there was no evidence of disease on CT imaging. We repeated the Signatera 4 weeks later. It had gone up to 0.54 from 0.38. At that point, I said, let's get a PET scan, which she did do, and the PET scan showed 2 small foci of activity in the peritoneum. Actually repeated a Signatera when she came back just a few weeks later to review the PET scan results, and it had really jumped up to 5.35. So I said, I think you need to go back on chemotherapy. She said, I can't do FOLFOX. We discussed various options. She agreed to oral capecitabine. At the same time, I said to her, you're young, you're healthy, you're fit. You may be a candidate for HIPAC. So she did go see a surgeon and did not find anything on laparoscopy, no evidence of disease. We repeated a Signatera at that time, and it had gone down to 0.06. So I guess she's responding to capecitabine better than I expected. So the question at this point is, what do we do? I think the Signatera was helpful here. Certainly, if they'd found oligometastatic disease at laparoscopy and done HIPAC, who knows, that might have been beneficial for her too. Of course, right now the surgeon's saying, I'm not going to give HIPAC to a patient with no evidence of disease in the abdomen.
So here are the questions for the faculty. One, what would you recommend for this patient at this point, which is fairly complex? How often should ctDNA be ordered in the surveillance setting? One thing that we already sort of discussed. And then for this particular patient, what would you have recommended if this patient's ctDNA had become positive without evidence of peritoneal disease on PET? Would you currently initiate systemic therapy based on the basis of ctDNA results alone in the absence of evidence of recurrent disease on imaging? Is there a particular level of ctDNA that you would be looking for to reinitiate treatment? So that there's a number of things in there to unpack. One of which, maybe Dr. Dasari, how do you use ctDNA in following people? Is it just positive or negative, or in a setting where you're looking for potentially curative disease to do something destructive to, does the actual amount mean anything, and how reproducible is that?
Yeah, a great question. So far, we've looked at MRD assay results as being binary, positive versus negative. Increasingly, what we're seeing is that perhaps it would be better to look at it as a continuous variable and also look at the level for a couple of reasons. Firstly, there is this entity of false positives, kind of very low-level positive ctDNA assay that perhaps could turn negative later down the road. And secondly, there are some emerging data, including some data presented today, that suggests that higher the ctDNA level, worse the outcomes. So
one last thing, because I'm told that we have to move on to the next case, because we've had actually lots of interesting questions. Do you ever restart therapy in someone like this who had at least some adjuvant just based on the ctDNA alone?
Solely based on ctDNA, a positive ctDNA assay, we don't have enough data to support restarting chemotherapy. Would that improve outcomes? We don't know. We often end up doing it, but the better thing would be to enroll these patients onto trials.
Yeah.
Okay. So next is Dr. Cercek, who has really done a lot of the seminal work in what she's going to discuss about non-metastatic microsatellite instability-high colorectal cancer.
All right, thank you so much. Hi, everybody. It's my pleasure to be here this evening. So I'm going to talk about immunotherapy in early-stage colon and rectal cancer, predominantly focusing on mismatch repair deficient or MSI disease, but I'll touch on MSS just at the very end about kind of what's going on in the future and what the future of this will be. So mismatch repair deficiency, or MSI, is definitely a biomarker in colorectal cancer. And in rectal cancer and early-stage disease, it's probably about 5% of all rectal cancers. And we know that these tumors are less sensitive to chemotherapy. There's been a lot of data that has emerged to this end. We first noticed it when we were treating our patients with rectal cancer with total neoadjuvant therapy. So we started with chemotherapy. This was in 2012 or so. And most patients did great, but a proportion of patients had progression of disease on FOLFOX or very rapid recurrence. And then when we looked back at our data set, we noticed it was a small number of patients. There's 21 patients, but they were all mismatch repair deficient. And of them, 29% of them had progression of disease on induction FOLFOX chemotherapy. And at that time, immunotherapy, PD-1 blockade, was already approved for metastatic mismatch repair deficient or MSI tumors. And so we were able to treat these patients then as if they had metastatic, recurrent, or unresectable disease, and they responded very well to immunotherapy. So this brought about the idea of our study, which really tested the hypothesis of using immunotherapy first with sort of the idea of total neoadjuvant therapy in early stage rectal cancer. So all patients with stage 2 or 3 rectal cancer that were mismatch repair deficient by immunohistochemistry were enrolled and eligible for the trial. They received 6 months of dostarlimab, which is a PD-1 monoclonal antibody, every 3 weeks. And then they had full evaluation with an endoscopic exam, MRI, as well as PET imaging. And if they had complete clinical response or no visible tumor, they were to undergo non-operative management. So the opportunity here was for just immunotherapy alone and foregoing all the rest of standard of care. If they still had residual disease, then they can go on to standard of care, long course chemoradiation, and then again could undergo non-operative management if the tumor was gone. And if it was still there, they could undergo surgical resection. So we had 2 primary endpoints. The first was overall response rate to either PD-1 blockade alone or in combination with chemoradiation. We ended up showing the data in publishing the data in 2022, where 14 consecutive patients had a complete response to dostarlimab alone. And based on this data, this was actually incorporated into NCCN guidelines. And so patients now with early stage rectal cancer, if the tumor is mismatch repair deficient, that's the most important first thing to check is by immunohistochemistry. They're eligible for PD-1 blockade based on this initial data from the trial. And then the second objective was looking at a sustained clinical complete response for 12 months after dostarlimab treatment. And this was really based on data in all rectal cancer in non-operative management, where we saw that the majority of regrowths actually occur right around the 1-year mark. And so this was kind of equivalent to a pathologic complete response rate. So we wanted to see the durability of this therapy. So this is the data, updated data that we just published and presented at AACR in April. So the first cohort was expanded. This is the rectal tumors. And we treated 49 patients. All 49 patients had a clinical complete response, and all 49 of them chose to undergo non-operative management. So 100% of the rectal tumors achieved a clinical complete response to dostarlimab alone in our study. And then we wanted to look at the durability of response. And so the median follow-up for recurrence here was 30.2 months, kind of a big range though. And 96% of patients were recurrence-free at 2 years. 2 patients developed recurrence. 1 had a very early local regrowth. She was restarted on dostarlimab and actually has achieved a clinical complete response and is now disease-free for over 6 months. And the second patient had regrowth in a high regional lymph node and underwent resection just of that lymph node and is now disease-free for a year. So both patients were actually salvaged, one with reintroduction of PD-1 blockade, which is an interesting topic of discussion, and the other one with surgical resection just of an isolated lymph node. Most patients achieved the complete response right around 6 months. We treated patients for 6 months, even if they had a clinical complete response at 3 months, which you can see a handful of patients did with the yellow dots on the graph. And then some patients took a little bit longer. And I think this is important to keep in mind now as this therapy is approved and is taken to clinics, hopefully everywhere, at least in the United States, that not everyone achieves it right at that six-month mark. And so some patients might need a little bit longer follow-up as long as the tumor is responding. So the AZURE-1 study is a global study led by GSK, which is a similar design, actually the same design to our investigator-initiated study of 6 months of dostarlimab. And then if the patients achieve a clinical complete response, they're followed by non-operative management. So the study has actually completed accrual in August, which is really exciting. And now we're waiting for the data to mature because the primary endpoint here is this sustained clinical complete response of 12 months. So hopefully by the end of 2026, this should have a readout, which will be exciting. The therapy did get a breakthrough status designation, but full approval will have to await the results of this trial. So in conclusion, 100% clinical complete response in 49 patients on our study. The clinical responses are durable. The adverse events, I don't have a table, but were very low in the rectal cohort. No grade 3 or 4 adverse events, predominantly dermatologic and fatigue. And the most important thing, I think, is for all locally advanced rectal tumors to undergo mismatch repair deficiency testing by immunohistochemistry in order to make that decision of total neoadjuvant therapy or PD-1 blockade as a first-line treatment. So moving on then to colon cancer, mismatch repair deficiency is likewise a biomarker. It's a bit more common here, about 10 to 15% of all early-stage tumors. Of course, the standard therapy for colon cancer includes upfront resection and then a decision based on adjuvant therapy, based on the pathologic staging, as we discussed a bit already. But we do have tumor-agnostic approval for mismatch repair deficiency for any tumors, including colon, of course, in advanced disease. So the NICHE 1, now 2 study was really the first pilot study to look at introduction of immune checkpoint inhibitors in early-stage resectable colon cancer. And it asked the very simple question: if we give 4 weeks, 1 month of combination therapy with a PD-1 and CTLA-4, so nivolumab and ipilimumab, and then patients underwent resection, what is the pathologic complete response rate? And so all patients from diagnosis had 4 weeks of treatment, and then surgery within 6 weeks of diagnosis. And these results are obviously beautiful, fantastic waterfall plot of 68% pathologic complete response rate in patients, again, who received here just 1 month of combination immunotherapy. I will point out that in the patients that underwent resection, there was a proportion of patients that did have node-positive disease. So the primary tumor responded and was gone, but the nodes were still positive. And I think as we think about this, and particularly taking it outside of the colon to other solid tumors, this is something that's very important to think about as to how we will distinguish whether or not there's residual disease, because it does get a little bit tricky here outside of the rectum. And the rectum, we're pretty spoiled in our assessment with MRIs and endoscopes. And then, of course, I think the most important and exciting part here is that the 3-year disease-free survival in this group was 100%. So no patients developed disease recurrence. There have been other studies that have looked at neoadjuvant therapy and mismatch repair deficient colon cancer as well. This was a study by Dr. Hu and colleagues of neoadjuvant single-agent PD-1 blockade, and also showed phenomenal responses. Here, about 75% pathologic complete response rates with 3 months of PD-1 blockade alone, so single agent. And then in MD Anderson, Dr. Ludford, Overman, and colleagues looked at this as well with pembrolizumab. So patients received 6 months of pembrolizumab and then underwent resection, and the pathologic complete response rate was 65%. So clearly very, very sensitive tumors to upfront PD-1 blockade. And the AZURE-2 study is now asking this question in a large multi-center study, including in Europe, actually globally, looking at dostarlimab, so perioperative dostarlimab in patients with untreated T4 and 0 stage or stage 3 dMMR MSI-High resectable colon cancer. So this will, I think, teach us a lot about staging, because the standard arm here is undergoing resection. Some of the things that we wonder about in this patient population is perhaps is resection alone good enough? Are they really advanced tumors, or is there just kind of this immune infiltrate into the lymph nodes? And so I think this study will be incredibly informative in terms of what our preoperative staging is and how reliable it is, particularly in colon cancer. And then, of course, the contribution of upfront PD-1 blockade on the primary endpoint, which is event-free survival up to 5 years. And then the ASIR-2, this, I should really touch on this at the very end, but this is asking the question of PD-1 blockade in mismatch repair proficient or MSS colon cancer, and really asking a scientific question more than anything in terms of is there any sensitivity, or what are the sensitivities, and what can we learn about which patients have mismatch repair proficient tumors that respond to dostarlimab, and why that is, perhaps with the tumors and the tumor microenvironment. So that will be very interesting, and that's ongoing in Belgium. And so just in summary, in terms of neoadjuvant immunotherapy for MSI-High colon cancer, obviously significant tumor regression, really impressive pathologic responses. But in all the studies that I showed you, the duration and the combination of immunotherapy was very variable, anywhere from 1 to 6 months. And what we saw, Dr. Rousseau led this effort looking at studies that have been published across the board. The longer you treat really does lend to better responses. Now, the question is, do you need to treat for a longer period of time, or do we need to treat for a certain period of time and then allow the immune system to take a little longer to work, as we saw with some of our rectal cancer patients? I'm not sure that we'll get the answer to that question, but it does certainly seem that the longer that these tumors are treated, the better the responses. And it logically makes sense, of course, because it is engaging the immune system, and you know, just by way of working, it may take longer in certain tumors, and certainly in certain tumor locations. So in terms of, you know, the question of organ preservation in rectal cancer, as I mentioned, MRI endoscopic evaluation do really correlate with clinical complete response. In colon cancer, the assessment of clinical complete response is challenging. In fact, we know from metastatic disease that up to 60% of tumors that really look like tumors on imaging, once they undergo resection, are actually pathologic complete responses, right? We've all been there. And so the question is, how can we really improve this? And I think this study by Dr. Hu and colleagues that I showed earlier really points to just our complete miss with radiology. If you take a look at this, the pathological complete responses are in red, the top row of boxes. And then you look at the radiographic responses at assessment, and really only one patient matched actually a pathologic complete response. The rest of the tumors just had really minimal regression, you know, or 50% regression, and really looked by all intents and purposes as if there was still residual disease. So a lot more work that we need to do here. I don't have time to get into it. We do have some data in our expanded study of solid tumors. ctDNA was actually a very helpful marker of clinical complete response. And then there's a number of ongoing neoadjuvant studies. And then adjuvant therapy, this will be presented on Sunday in the plenary session. I think we're all very much looking forward to these results. So this study asked the question of resected stage 3 mismatch repair deficient tumors. Is there a benefit of adding immunotherapy, PD-L1 blockade, to the backbone of FOLFOX chemotherapy? So patients were randomized to either FOLFOX alone for 6 months or FOLFOX plus atezolizumab for 12 cycles, and then atezolizumab alone for an additional 6 months. So this will be the first talk of the plenary session this Sunday, and I'm very much looking forward to it. And then just very, very quickly, is there a role for immunotherapy in mismatch repair proficient colon and rectal cancer? I think yes. I think this is certainly in clinical trials. It's incredibly important. The Niche 1 study, as I mentioned, kind of did a pilot question of what can we accomplish with immunotherapy for 4 weeks. It was not just used in mismatch repair deficient tumors, also in proficient, and we did see responses here. And then the NEST study, which Dr. Cassie led, Unicorn and Neo-Oasis studies have all shown pretty impressive responses with neoadjuvant immunotherapy combination checkpoint blockade in MSS disease, both in colon as well as outside of the colon in other solid tumors. So I think there's a lot more to come from this. There's many, many trials in rectal cancer looking at this, most actually in combination with other therapies such as radiation or chemo, so it's a little bit tricky. And then we have a study.
They're telling us we have to go on.
We have a study of in combination in rectal cancer. So I guess that is all I have to say about that. Thank you.
We still have the discussion.
Sure.
Mm-hmm. Okay. So I think next is a video.
Tonight, our group is also presenting a CME symposium of a disease subtype that used to be considered uncommon, EGFR mutant non-small cell lung cancer. And on that note, consider that the next case, presented by Dr. Malik, represents a disease subset in colorectal cancer with an incidence maybe not that much different than EGFR mutant lung cancer, MSI-High colorectal cancer, which is likely to garner even more attention after Sunday's plenary presentation of the Atomic trial. Dr. Malik describes a clinical scenario that every medical oncologist eagerly awaits.
68-year-old Hispanic male who was diagnosed with rectal cancer. MRI showed T3N1 disease on initial diagnosis. I was getting him ready to start him on 5-FU oxaliplatin. His MSI and MSH testing came back, and he was found to have an MSH6 mutation. So this was one of the first patients I was able to start on immunotherapy. So he started dostarlimab and received 6 cycles of therapy, and we repeated an MRI, which showed a 50% reduction in the size of his rectal mass. He went back to see colorectal surgery. They did a colonoscopy and biopsy, and there was no evidence of any active disease. More recently, he visited with the surgeon, and they thought that he was a good candidate for surgery because he had such a good response of the tumor away from the anal verge. So he's going to go for surgery, and he was spared the chemoradiotherapy part of the treatment.
So what questions do you have about this case?
In patients with MSI-High tumors, how long do we use the dostarlimab? And do we continue this after surgery if the patient does have residual disease? When the MRI shows a 50% reduction, for those patients, are they safe to go on to surgery directly? If patients have a good response on MRI, what patients can we avoid surgery on? And then how long do we continue the immunotherapy in these patients? Would it be beneficial to monitor these patients' ctDNA?
So questions. 1, should all patients with locally advanced CRC undergo MSI-MMR testing? Which patients with MSI-High MMR deficient disease should be offered neoadjuvant therapy with an immune checkpoint inhibitor? And then the other question is, when administering neoadjuvant dostarlimab with MSI-High or MMR deficient locally advanced rectal cancer, how long should it be continued? Should it be continued in the adjuvant setting for patients who have residual disease at surgery? Dr. Cercek, you have probably more experience with this than anyone else. Your patients, I don't think any, at least in your initial trial, none of them ended up going to surgery. So my first question is that how would you evaluate the patient that the surgeon tells you still has residual disease?
Yeah, I mean, I think this tumor was clearly responding. I think the doctor mentioned that the patient received 6 cycles, so that's not quite 6 months. And if the tumor's responding, I would not take the patient to surgery. I would continue treatment, absolutely, and give the patient the benefit of the doubt, because probably they will get there and not need surgical resection. So we have not had the issue of taking anyone to surgery or needing to think about the adjuvant setting.
Would you biopsy it if there's any question?
Yes.
Because that's the other, as you have pointed out, that not all masses are tumor in MSI patients.
Absolutely. So I think that's a really important point. So in rectal cancer, we know that the MRI actually lags in response. So the endoscopic response comes first and is much more telling. The biopsy can be negative, but really the most important thing is, even if there's some potential disease still on MRI, just to definitely continue for at least 6 months, and to, if the tumor is still responding, to allow that response to continue.
And what's the longest, last question, because we have to move on, they tell me, what's the longest you would treat someone going for a response?
I have treated, so the patient that developed this recurrence, we treated for another 2 months only. So I've only done, 9 months or so total. I've seen patients come in from the community that were on it for a year. It's very well tolerated, so I don't think there's a problem.
One quick comment, Dr. Hecht.
I think they need us to go. I have lots of questions for you, but I think they want us to go on to the next video.
The next case, presented by Dr. Rupard, is a 38-year-old oncology nurse with Lynch syndrome who was initially worked up for iron deficiency anemia and ended up having a 5-centimeter adenocarcinoma removed from her ascending colon. And here again, Sunday's presentation of the Atomic trial will have great relevance.
This is an interesting case, Neil. In sitting down with her and talking to her about this, she was a bit sheepish. She felt like she should have known all along, because within about 2 years of each other, 3 of her sisters were diagnosed with colorectal cancer. And her father had also been diagnosed with it. Additionally, by the way, she had a sister with ovarian cancer, which also goes along with Lynch syndrome. So this mass was resected. It ended up being stage 2A disease. And because of that, we did not offer her adjuvant therapy. But because of the Lynch syndrome, she was offered a hysterectomy and salpingo-oophorectomy, and she undergoes serial colonoscopies, basically 1 a year. So a few questions for your faculty members here, Neil. For a young patient like this, would you be more or less inclined to offer adjuvant immunotherapy given her deficient mismatch repair MSI-High status? I'm also curious as to the role of circulating tumor DNA. This is outside of the typical use of that.
Any other questions?
I'm curious how aggressive your faculty members would be about her sisters. So her sisters are also all in their 30s. How aggressive would they be about getting her sisters tested and doing some prophylactic treatments such as the hysterectomy, oophorectomy, et cetera? And a question that comes up a lot from these patients, and I know the textbook answer, but I'm really curious what your faculty have seen, and that is, when women are diagnosed with a hereditary cancer, they all want to know, what's my risk of breast cancer? And the textbook answer to this for Lynch syndrome is it does not appear that there's an increased risk of breast cancer. But I'm curious what your real life experience has been with that and what you've done to ease the concerns, the very understandable concerns of those patients who are diagnosed with Lynch syndrome at a young age.
So questions. What adjuvant therapy, if any, would you have recommended in this woman's case? Given her young age and MSI-High status, is there a role for adjuvant immunotherapy? Well, we will have more information. At this point, would you consider monitoring her using ctDNA? Given this patient's family history, would you recommend genetic testing and risk-reducing surgery for her siblings? Have any of your patients with Lynch syndrome developed breast cancer? And I can answer, yes, but it's rare. And so that's MSI-High. How do you counsel your patients with Lynch syndrome, particularly those who are younger, about the risk of breast cancer? Not a lot. Now, Dr. Cassis, you were actually asking a question before, so you get the honors for this, and it does actually overlap with your interest in using checkpoint inhibitors as well as ctDNA. So you have this person 2A Lynch syndrome, and what would you do with someone like this?
I think
other than not worrying about breast cancer.
But I think kind of building on the last 2 presentations too, if there's one indication of using MRD, especially in this day and age, to a person who's responding to checkpoint blockade, for example, that's a good case use in the real world. The MRD negativity there would be very reassuring in terms of just keeping the treatment going, not having to worry about stuff on the scans, because we discuss these cases almost every other tumor board, and there is definitely, they don't meet criteria for clinical complete response on MRI, but we know from Niche and Dr. Cercek work and all the other work that there's no rush to take them to surgery or escalate or switch therapies. So I think that could be a good use of ctDNA for a patient who's on immunotherapy for MSI-High, whether it's stage 4 or early stage, as Dr. Cercek
I'm
pointed
going
out.
to take the moderator's prerogative for one thing, and the answer is yes, genetic testing. Okay, that's right. I know they're telling me we're going over, but yes, this is where you save lives. I can think of one family that, because I like Dr. Van Cutsem, originally a gastroenterologist, and I used to see Lynch patients, and where the father knew they had Lynch, and both children, both sisters, ended up having MSI-High colon cancer because no one talked about it. This is where we save lives. So yes, these patients, and in fact, I would say that's the standard of care. You need to send them to your geneticist. Okay, so now, Dr. Cassi?
Yes, so I was going to build upon some of the ctDNA discussion, but more so in the context of metastatic disease, and a topic that I do like to discuss with my patients and also fellows. This quote-unquote oligo The best part about the oligometastatic disease is nobody knows what oligometastatic disease is, so it kind of beauty lies in the eye of the beholder. So I'll build upon the ctDNA, as Dr. Dasari laid good foundations about, but kind of focus more on the relevance in advanced disease. And then we'll talk about liver-only, liver-dominant, or oligometastatic disease as to at least some of the data that might be practice-changing. So as Dr. Dasari rightly pointed out, there's a lot of data about MRD, and those are a lot of tumor-informed assays. In the context of metastatic cancers, you're using more commercially available next-generation sequencing-based assays that are DNA-based. There's also some response assessment tools for tumor-informed as well as methylation-based assays. So the good thing is there's a lot of data. In fact, a lot of the liquid biopsies, is a lot of the folks in the audience who are oncologists, was actually in the context of advanced or metastatic tumors, or, as Dr. Love was pointing out, the EGFR mutant non-small cell lung cancer, treatment response, acquired resistance mechanisms, the story of a lot of the precision medicine that started in lung cancer is being replicated in the world of colorectal cancer. So again, to reiterate, and also as you look at presentations at ASCO, do pay attention to the methods, because not all assays are alike. Even the same assay from the same company is not the same performance as it was a few years ago. And there's a lot of nuances, the same data set. So if you get a chance, Dr. T, who presented data today on her Dynamic 3, they did redo analysis of their Dynamic 2, which was published in New England Journal, and the results look very different, and the false negativity rate changes as you have a better assay. So do pay attention to the methodology. While the strategy is important and the methods and the treatment arms are important, the assay may be a decisive factor, as we found out a few years ago with the COBRA study that Dr. Dasari mentioned. It was halted early, and some of that might have been an assay issue. Also, add further confusion to the mix. Every company or platform or scientific unit is coming up with their own units of measurement. In fact, an hour ago from Dr. T's work, I heard another term, something called tumor-derived molecules, so TDM. So, we're used to weight in percentages. Is that the same as mean tumor molecules, parts per million? So, having some idea is helpful, because, as to how do we explain some of this information to patients. And of course, there's a lot of heterogeneity. You'll hear from Dr. Van Cutsem about how the molecular testing is shaping. In the context of colorectal cancer, which is increasingly getting more options, especially on the right side of the table here, the tumors have intratumoral heterogeneity, but over time they have temporal heterogeneity as well, which makes tumors, it's not safe, feasible, or practical to be biopsying again and again. But one indication is kind of using ctDNA to determine first-line therapy. And 2 hours ago, we heard the first practice changing, I would say, in the world of GI cancers in ASCO 2025 was the final readout on the breakwater regimen, which is for BRAF V600E mutant colon cancer. Again, not a small percentage of patients. These are 8 to 10%. So identification of these patients early on is relevant. From the paradigm study, selecting the ultra selection of the RAS, RAF, wild type. Of course, the sidedness to begin with, HER2 negative patients who could benefit from anti-EGFR therapy. So, and then of course, you heard from Dr. The team on the checkmate on the Nivo, Ipi, and Pembro, the MSI, which is about 4 to 5%, not as many as we have in stage 2, 3, but less proportion of patients who have MSI-High, mismatch repair deficient disease. No longer can a FOLFOX with BEV regimen or a chemo plus anti-VEGF appropriate for every other patient in front of you. So opportunities for personalizing therapy first line are more relevant now than ever. And just to summarize the data for anti-EGFR, again, we have multiple database studies. The first randomized studies, that was Paradigm, ultra ctDNA selection. There's almost a year worth OS difference, in a patient who is truly a candidate for anti-EGFR. That person potentially should get anti-EGFR, and I think that's where liquid biopsy can help. And I'll show you why that's relevant, because, again, not to replace tissue testing as a complementary role to tissue testing. This is a prospective study done by the group in Japan. They prospectively had a system of getting NGS testing done tissue as well as liquid at their own institution, and they screened over 5,000 patients. So again, it's not just my institution, your institution. The average turnaround, you'll be lucky if you get NGS testing back within 4 to 6 weeks at times. And to be told 4 to 6 weeks later that you need more tissue for testing, adds further to the problem. Again, this is from 2020 Nature Medicine paper. The turnaround test is a lot of us in the US know, has gone down to 6 to 7 days or 8 or 9 days, depending on which part of the US you're sending the sample from. So this can be very helpful because, again, nothing against the pathologists in the audience, if there are any, or on the video call. This is all the centers in the country. Every time I talk to the pathologist that I was at Mayo Clinic or Cornell or now City of Hope, every single one of them says, I will get you the results within 2 weeks. We do things differently, but this is the national readout. 81% of the time, you do not have testing back from any of the best centers of the world, no matter what their ranking is. It just practically, there are hindrances, and that's also 2 weeks when you have sample in-house. All of us see patients from community oncology where endoscopy is done by some random gastroenterologist, or we're seeing patients for second and third opinion. Sometimes getting tissue. I was right across the street from Dr. Cercek in New York. Between New York, I think you can do any task, then get tissue from each other. So it's very challenging at times. So I think the barriers for liquid can be helpful, and not only for first line, but now, especially our colleagues in Europe have led the way here. EGFR rechallenge is an entity that's relevant. And there are now 4 published trials, the so-called, all 3 of them started with the letter C, Cricket, CAVE, Chronos, and now more recently, Velo study. At least it points out that you can spare the toxicity to your patients who are now liquid mutants. So they were, of course, RAS-RAF wild type on their tissue 4 years ago, 3 years ago. The median survival, the peritoneal paper just published presented from our colleague in Arago at the GI session, was quoting a median survival of 55 months. So our patients are living in the order of 4, 5, 6 years. So again, if your patient is liquid mutant today, meaning that ctDNA has acquired RAS, RAF, MAP kinase, pathway alterations, EGFR, they will not benefit from EGFR. They'll only get the rash and toxicity and no benefit. So at least spare them the toxicity. Again, the EGFR rechallenge data is, the curves separate out, and there's definitely responses, but you definitely want to recheck your patient's liquid biopsy before you consider EGFR rechallenge in later line. And then, shifting gears to as a rapid surrogate for tumor response, this is not just for colorectal cancer, regardless of the assay, a tumor-informed. In this cancer discovery paper, this is Nature Cancer, a plasma-only assay. If you clear ctDNA, again, these are all metastatic, all solid tumor patients. Doesn't matter, which disease, what therapy you're giving, especially clearance patients. These are the ones who are alive years out. And then any decrement is helpful. And we presented this data at ASCO GI a few years ago. Between a patient responding, and that could be any decrement of 20, 30, 40, 50 clearance, the survival almost doubles. So very early on, within first month of therapy, if you have a baseline liquid biopsy and you repeat another liquid biopsy, you could be separating out people who are median survival is less than a year versus not even reached for the ones who are. So again, I think there is an opportunity to prognosticate, but also an opportunity to consider trials using ctDNA kinetics. Segue to the last topic, which is oligometastases. I had a chance to talk to Dr. Weichelbaum, who's actually here in Chicago. He's a radiation oncologist. He was telling me back in 1994, when they were trying to publish this paper in many of the leading journals, they were shunned and questioned and ridiculed, and it was very hard to publish this paper. And if you get a chance to read it, it kind of questions the argument that, are we giving cancer too much credit? Maybe the sites of metastases are all the sites that you can see and visible, and maybe just a palliative, writing off your patient is not the right approach for, at least for colorectal cancer. And I would say, besides other cancers, I think colorectal cancer, and some of the work is from our colleagues at Sloan. You look at the paper from New England Journal from 2005, taking patients with liver metastases to curative surgery, 5-year survival, 10-year survival. And again, this is with not even much systemic therapy available at the time. On the top, you see these 5, 10-year survival curves from resection of liver-only metastatic disease. Same principles in ignored poster child as lung-only metastatic disease. That is a patient population you want to pay attention to. And the bottom half, something that's really picking up, as you can see from the graph on the right lower quadrant, it's the use of liver pump or hepatic arterial infusion pump in addition to the surgery in the adjuvant setting. There's a nice ASCO Post article published by Dr. Cercek and colleagues that talks about the dilemma and where the field is at. So For the liver-only disease, this is something to consider as it's adding to the number of people we can cure with stage 4 disease. Finally, a plug for the TransMet trial. So these were patients with unresectable multifocal metastatic disease to the liver. Again, this is the intention to, this is the per protocol analysis, so the patients who actually made it to liver transplant, 73% versus 9%. That's a big number to look at. And within the United States, there is a flurry of institutions, almost several institutions we ourselves have done 8 transplants, but it's a rigorous process. For the 8, we probably saw 500. So just something to keep in mind, involve a transplant center colleague, or at least have a formal evaluation, because these patients need to be identified early. Simplistically, they have to have at least 1 year minimum of disease control and at least 6 months of removal of the primary and liver-only disease to qualify for transplant. Again, there are nuances between criteria, but for the most part, you want to identify these patients early, and an early referral is important. And again, is the person with liver-only disease on panel A on the left side oligometastatic? What about the guy with 3 lung and both sides, or 3 liver, 2 lung? Is that pushing it? Just a plug for a trial which is called Erasure. It's open. It's pushing the boundaries to even 4 organ systems. And finally, just one word of caution. The only place where anti-EGFR led to very provocative and actually negative results, in a purely resectable colorectal cancer patient, you just want to focus on chemo and or anti-VEGF, but avoid anti-EGFR. Not only did it not help, you can see a median survival difference of 30 months. We don't still know why that happens, but it's not surprising. Anti-EGFR in the adjuvant setting did not help, maybe harm. A purely resectable stage 4 might be the same person. I had a couple of articles, I'll put them in the slide deck so you can draw reference to them, but with that I'll stop and we'll go on to the case discussions.
Okay, thank you very much. Now we have some more cases.
The next case from Dr. Zafar was a young man with T3N0 cancer of the sigmoid colon.
Very healthy guy, 51. We talked about potentially doing adjuvant treatment. His post-op ctDNA was negative at that time. And then he didn't want to do any more aggressive treatment. He wanted to avoid a port. But in the end, he decided, he'll just do single agent CAPE, which he did for about 6 months. Stayed ctDNA negative and markers were clear. All the follow-up surveillance was clear until April of 23. That was his first ctDNA marker that was positive. Nothing happened until November of 24, where we detected radiographically a liver lesion in the left hepatic lobe. Then he had a partial hepatectomy with clear margins, no evidence of residual disease. Post-op ctDNA is negative, so he's NED in some ways. And then we decided that should we watch or should we consider some form of an adjuvant treatment? And he was scared enough that he wanted to do something just regardless of the ctDNA. But of course, it's not clear what is the right thing to do in such situations. So I would be interested to see if patients who have no evidence of disease, albeit in stage 4, if they're ctDNA negative, post-op with curative intent resection, is there a strong clinical rationale to utilize some form of an adjuvant treatment in this situation versus just surveillance and follow-up?
So questions. 1, what adjuvant treatment, if any, would you recommend for this patient? In your opinion, how effective is ctDNA monitoring in patients who have undergone curative intent resection of oligometastatic colorectal cancer? Can patients with negative ctDNA after resection of oligometastatic colorectal cancer safely forego adjuvant treatment? How would you approach surveillance for these patients? I'm actually going to start. One is that, wow, this is the patient we want with these single metastases. Yeah. I remember that I saw a patient years ago, just to show how things change, from your current institution, and it wrote multiple liver metastases. There were 2. And so now that's, once again, that's kind of a chip shot for our liver surgeons. I think the best data for adjuvant that I've seen is the Japanese trial, which really sort of answered a lot of questions. So overall, what they did was they gave an oxaliplatin-based regimen in patients who underwent liver metastacectomy. And overall, the trial was negative, but really the gold, the pearl was in the forest plots. Not surprisingly, and this is how we had done it, if you've already had an oxaliplatin-based regimen in the adjuvant setting, giving more, and I see this all the time, really had no benefit. On the other hand, if you did not have an oxaliplatin-based regimen, beforehand, then giving, actually did make a difference, and it was significant. This patient kind of splits the difference because they had a fluoropyrimidine by themselves, but in this particular patient, I would go ahead and based on that data, give oxaliplatin-based. Now, the other question is how long? If I remember correctly, they did 6 months, even though we do 3 months now for many of our adjuvant, and I think that's reasonable. Anyone else have any other thoughts? Eric, what would you do in such a patient?
Yeah, this is stage 4, although it's oligometastatic. So we would propose an additional chemotherapy. Often in Europe, if we make the diagnosis of oligometastatic disease, we would go probably for perioperative chemotherapy. Remember the long older study that was done many years ago? Perioperative chemotherapy in patients with up to 4 metastases, so oligometastatic disease, resectable disease. In this situation, there was an improved outcome for these patients. If the patient was operated, then we would usually give adjuvant chemotherapy. The 3 versus 6 months is more for stage 2 and 3. Data. In stage 4, we don't have any data on the duration. If tolerance is okay, we usually go for 6 months in this situation.
Okay, any role, just last thing, because any role for ctDNA in such a situation, I don't think that it would tell me necessarily what to do, because this patient will be followed very closely. This comes up anyway. I guess we're supposed to do the next one. So let's go ahead with the next video.
The next case, presented by Dr. Chen, is another young man, in this case, presenting with a locally advanced MSI-High colon cancer.
This is a 44-year-old male who initially presented with stage 2B left colon cancer, however, high risk with perforation. Surgical pathology demonstrated a PT4A and 0, and with positive margin, tumor extended into the pericolic connective tissue with the involvement of serosa as well as extension into the retroperitoneal margin. The IHC showed loss of staining for MLH1 and PSM2. NGS testing showed MSI-High. He did not get adjuvant therapy. However, then in December 2023, he had evidence of recurrent disease with peritoneal carcinomatosis. He did not want any chemotherapy. Therefore, pembrolizumab, a single agent, was started in January 2024. And we continued with circulating tumor DNA testing, which actually has been more helpful than his CT scan because of peritoneal carcinomatosis. When we detected his recurrence, his circulating tumor DNA was actually quite positive. And then after we started pembro, we can follow that circulating tumor DNA, came down. But as you see, most recently, the circulating tumor DNA become a little bit positive again. And his CT scan at this point actually is quite stable. So we continued him on pembro. And some of my questions would include, how do we interpret this subtle difference in the circulating tumor DNA? Does it mean that we would need to change management for this patient? And what will be the next best treatment for this patient at progression?
So questions. In your opinion, how effective is ctDNA testing to monitor for response in patients with metastatic colorectal cancer receiving systemic therapy? How would you interpret the slight increase in ctDNA in this patient's case? Would it prompt you to switch therapy in the absence of disease progression on imaging? What therapy would you recommend next for this patient? This kind of is a lead into my talk, actually, but does anyone want to jump in on what these small changes in ctDNA from negative to positive and what the numbers mean?
I sometimes give the example that it's kind of like the fish in the ocean. The fact that you see it and you don't see it, it doesn't mean it's gone. When you have low levels of shed and peritoneal metastases, like this patient had carcinomatosis, as you saw from Dr. Cercek's data and some of the changes of ctDNA that was shown by this case, by this physician, was very early on. So it will take time, even in the non-metastatic setting, 6 months, 8 months for checkpoint blockade to work. And in the metastatic setting, checkpoint blockade right now is for 2 years. So very early on, these minor fluctuations you saw on the curve, it's like a triangle, it's barely detectable. So it's not that the DNA had completely disappeared. It probably was below the threshold on the first 2 negative evals, but they were probably false negative. A deeper assay probably might have picked it up. So I wouldn't change management. I would continue and stay the course. Clinically, the person is responding. You have a scan that shows stable disease. So again, interpreting everything in the clinical context, you would just continue and monitor. And it's just that I don't think it's the false positive. The other one is probably a false negative when it's very low fluctuating levels.
Anyone else have any thoughts about that? Okay, so stay the course. All right, so let's go ahead. I think I actually am, this was a sort of a segue for me. I'm Randy Hecht, I'm at UCLA, and my charge is to talk about the role of immune checkpoint inhibitors in the management of MSI-High colorectal cancer. So in some ways that we don't even need to talk necessarily about the background. This has already been the seminal paper from Lee and then Luis Diaz is the senior author. It's hard to believe that it's been 10 years now, and it's really revolutionized how we think about patients and how we treat patients. As a GI fellow, I sat at the multi-headed microscope and looked at the Crohn's-like, for patients who had Lynch syndrome. And really what it was telling us was that the pathologist, as always, we should listen to our pathologists, and there are lots of infiltrating lymphocytes. But you can see that these patients have lots and lots of mutations. And of course, as we know and we've discussed, are very sensitive to immune checkpoint inhibitors. And this is sort of from the original New England Journal paper showing an incredible response and changed how we treated these patients. So this led to a number of trials. One thing we don't have a shortage of are different checkpoint inhibitors now. And so while we had a couple at the beginning, there's so many, and we've now reached the point that they're getting to names that I can't pronounce, even as an oncologist. And so some of the original trials were done, not surprisingly, in previously treated patients. That's usually where we start in drug development. Checkmate trials with nivolumab and nivolumab ipilimumab. Keynote with pembrolizumab. I'll skip Nipicol, and then, of course, updated today some of the Checkmate data, some of which was in previously treated patients. So what we showed was basically that when you look at larger data sets from that was presented in that original New England Journal paper, this is updated, that's why it's 2023, which you can see in both second line and even further in salvage, that you see that patients who have who are MSI-High or deficient DNA mismatch repair, not only do a large percentage of them do well, but they can do well for a really long time, and these curves really flatten out. This was also seen with nivolumab and ipilimumab in the salvage cohort. One thought was, can we compare between trials? Because that's what we do, and you probably should not. But one of the questions, of course, that came up and was later answered was dual checkpoint inhibitors versus single checkpoint inhibitors, because it did seem that the combination may look a little bit better. What about other checkpoint inhibitors? I don't think that there's really any huge difference between any of these. As I tell my patients, Coke, Pepsi, Shasta, Royal Crown, they're all colas, and great value. It doesn't matter what they are. And so there was a trial with dostarlimab in the metastatic setting, the Garnet trial, and this actually over to the side is all MSI-High patients, but really the colon cancer patients did as you would expect, and they ended up getting a tumor agnostic. There are other ones like tislelizumab, serplulimab, and you're basically PD-1 here, and they all look very, very similar. I don't think there's a huge difference between PD-1 and PD-L1 either. So what about first line in MSI-High metastatic colon cancer? There was the Keynote 177 with Pembro versus chemotherapy, a phase 3 trial. We talked about Checkmate, where there was a first-line cohort, and then we'll spend some more talking about the Checkmate 8HW that Heinz-Joseph Lenz helped update today. So this is, wow, it's harder for me to see from here as my eyes age, but what you can see, this was single-agent, first-line, pembrolizumab versus chemotherapy. And what you can see is that this is, even though it's hard for me to read actually the numbers, even with my eyes, I can see that these curves are clearly different. And so showing that really this would be the standard of care, particularly the top, which is PFS. So in the first-line cohort with Ipi-Nivo, the curves are actually bumping up against the top of the Kaplan-Meier curve, and which you can see for PFS, and that is really quite high, and very few patients are falling off. And as was mentioned earlier, is that these are plateaus. We'd start talking about not just progression-free survival, but perhaps even cure. So this led to the Checkmate 8HW trial, which was a fairly complicated trial in that there were multiple cohorts, there are multiple comparisons, and there are also multiple lines of treatment. So the first one was presented by Thierry Andre. This was presented at ASCO GI in 2024 and published simultaneously. And what he looked at was the nivolumab plus ipilimumab versus investigator's choice chemotherapy. And once again, these are not subtle. For at one time there was what was called the Ellis. The Ellis difference, where you're trying to look at a hazard ratio of 0.8 for something to be clinically significant in metastatic colon cancer. And what you can see is that this is actually a huge difference between nivolumab and ipilimumab, and led to its approval in first line. Now, more recently at ASCO GI, the other cohort was presented. And this was not just first line, but also included patients in second and third line. And this was, once again, comparing the nivolumab and ipilimumab versus nivolumab alone. And this was also simultaneously published, in this case in The Lancet. And what you can see is that this is progression-free survival, that the combination of nivolumab and ipilimumab, while nivolumab by itself did remarkably well with a plateau, but there was clearly a difference over the entire curve. This was updated earlier today by Heinz-Josef Lenz, who's across town from me at USC and has done a lot of the work with this. Well, I think one of the more interesting things from this, and I think I need to spend more time going through the data, is they looked at PFS2. And those of us who take care of patients who have MSI-High, who progress, because remember, not everyone is in the plateau, is that these patients seem to do well anyway. And they do well in their salvage, and then also sometimes they do well even in continuing. So I think there's a lot more data out of this trial. So basically, we know that nivolumab and ipilimumab improve progression-free survival in MSI-High. It's actually hard, it's getting to look at overall survival to a certain extent. Single agent, I think, is still acceptable, and I look forward to a robust discussion about 2 versus 1 checkpoint inhibitors. And then this is a segue into what my other charge is, to talk about toxicity. So the people in this room are probably in some ways better at managing immune-related adverse events than the GI oncologists, because historically you are the ones who have been using it in melanoma as well as in lung cancer. So just talk about, there doesn't seem to be a huge difference in colorectal cancer. How do we manage them? When you have an IRAE, immune-related adverse event, does that have an effect on efficacy? And then the question is that can we reduce exposure? We talked earlier about length of treatment that people are on, and the other question is does everyone need combination therapy? So this is actually from the Journal of Immunotherapy of Cancer, or JITC. This is a pure colon cancer cohort, and as you can see, and everyone's familiar, that almost anything that can be inflamed, can be inflamed. And one of the things that they did leave out, though I have seen, which is probably more feared even, is myocarditis, but there doesn't seem to be a real difference with colorectal cancer and the other immune-related adverse events that you're familiar with seeing with other malignancies. There's also from this paper, we talk about early versus late immune-related adverse events, but I've certainly seen all of them at different times that don't necessarily read the script. I just wanted to put this in here really more for the enduring, because you certainly cannot read this from here, but there are a number of organizations that have come up with how to manage. And I think it really, really is important to follow these guidelines. ASCO, this is the ones that I took, have their own guidelines, their NCCN guidelines, as well as SITC guidelines, Society for Immunotherapy of Cancer. And I think one of the things that's really important is, one, is being aware of the adverse events. Two, that make certain that the patient tells you about the adverse events in between times, so make certain that they're aware that they need to call you. And three, early, and we'll have to talk about how aggressive, but early treatment probably makes a difference. One of the questions that comes up, and I don't think is really well defined outside of melanoma, is what happens in someone who has who's on 2 checkpoint inhibitors and has immune-related adverse events. So does it affect efficacy? From that same paper, there was some small differences, but the numbers are small, really no difference in overall survival. What about treatment? We're always concerned, we're treating the patient to try to make certain that they're cured or that plateau. And so corticosteroid, there was an interesting paper across multiple types that was published in JCO last year that actually peak dose may be detrimental. However, the cumulative dose was not in outcomes. Do all patients need dual checkpoint inhibitors up front? I think some of it are clinical factors. If someone has a large burden of disease, if someone has other comorbidities, such as autoimmune disease, if someone needs a response, I think that we're really in the infancy of looking. There was a really interesting paper from France that was published in the European Journal of Cancer with a sort of almost looking at radiologic differences between patients, and they were able to separate patients into a low risk and a high risk group. And in the high score population, having combined was better, while those patients who had this low risk, low score, it didn't seem to make any difference in outcomes. I think this is really early, but I think this is the future. How long to treat? There was at least one paper that I was able to find from Margalit, and in other diseases, it's unclear whether more than 2 years really makes any difference, and as was mentioned earlier, that's become our standard. But this is actually data in colorectal cancer that patients who had more than 2 years versus less than 2 years did not seem to make a big difference. So to summarize, one, I think it's really important, as has been discussed multiple times, to identify MSI-High or deficient mismatch repair in colorectal cancer, whether it's in the adjuvant setting or first line, second line. That we know that checkpoint inhibitors are now the standard of care. We know that combined checkpoint inhibitors seems to be better overall than single, and definitely better than chemotherapy. The toxicity is real, and different than chemotherapy. Then finally, what I think a lot of the research for the future are, one, I think it's important to know who does not need a CTLA-4. Two, we use the same drugs. We've been throwing the same drugs at patients for a long time. Are there better, newer agents to treat patients who have IRAEs? And what about the rare patient, who does, or not so rare patient who does progress? There are other IO agents that are being looked at. I think the WRN helicase inhibitors are really interesting, and there are trials that are out there. One of my colleagues at UCLA, but there are other institutions have that. So now we go to a case presentation. Thanks.
The next case is from Dr. Divers and highlights the challenge of systemic treatment of MSI-High disease in older patients.
Quite functional 81-year-old female, really. And she came in with some cramping abdominal pain and some lower GI blood loss. CT showed a right lower quadrant mass involving the cecum. So she underwent a partial colectomy about a year and a half ago. Pathology showed a T4N1 adenocarcinoma. It was MSI-High. Again, MLH1 and PMS2 deficient. We did offer adjuvant K-pox. She received 1 or 2 cycles and had extremely poor tolerance to oxaliplatin, which you might see, in an 81-year-old in that case. She declined further therapy. In less than 6 months, she had recurrent disease with implants on the anterior abdominal wall, which were palpable on exam, and also pelvic implants, which were biopsy-proven recurrent adenocarcinoma, again, MSI-High. She was placed on single-agent Pembro, had a complete response to all sites of disease on CT and PET, and she completed a year of Pembro, and due to financial constraints, she discontinued that in December of 24 and has been off therapy since with no recurrence.
Any questions about her case?
Yeah. What's the role of BRAF in these patients, right? I mean, now that we have, data that came out, I think it's a breakwater trial looking at encorafimab and cetuximab. So because a fair amount of these patients may have some BRAF mutations in the somatic setting. So I'm just curious to see, what the thoughts would be on a path. I mean, obviously the toxicity of Pembro is probably a lot less than the others here, but would one think differently sequencing those?
So questions are, one, how frequently have you encountered patients with MSI-High BRAF mutant colorectal cancer? How do you generally sequence immune checkpoint inhibitors and BRAF-targeted therapy for these patients? Are there any situations in which you would start with BRAF-targeted therapy? Maybe, I guess I'll continue. For a patient with MSI-High BRAF mutant colorectal cancer who experienced disease progression on first-line pembrolizumab, what would you recommend next? The breakwater strategy of FOLFOX, encorafenib, and cetuximab, or encorafenib and EGFR alone? Would patient age/fitness have any bearing on your decision? So I will start, and the answer at the beginning is yes. It's actually fairly common. The numbers vary depending on the data set, but it's probably a good minority of patients. And of course, the patients who have BRAF mutations are patients who do not have Lynch syndrome. So it's actually useful, and this should be part of your testing, whether it's a full NGS panel or not. How do you sequence? I think that as the physician mentioned, probably in general, checkpoint inhibitors are better tolerated. And also, if you look at how patients do better. Does any of the, I'm going to pick on Dr. Dasari, any idea which would you do first? Would you do in someone who had both a BRAF mutation and was a sporadic MSI-High?
Yeah, I'd probably favor immunotherapy in these patients over BRAF targeted therapy. It's a question of whether it's the driver alteration versus the passenger alteration. There is an ongoing trial that is looking at exactly this patient population combining anti-BRAF therapy with
immunotherapy.
CMARC, yeah. That'll provide us some additional guidance.
But I think that's going to be a very interesting trial because people do so well with single or dual checkpoint inhibitors. Does adding at this time, really, does it move the needle? Does it, or are you just adding a significant amount of toxicity? So then, for the patients who progress, what would you do next in someone who, so this patient, I think for this, I don't know if it's any patient, but let's say a hypothetical patient where you could do chemotherapy, what would you do after that in someone who progressed on pembrolizumab? Would you try to push harder on an immune therapy? Would you add, Dr. Kasi has published on this, as we've talked about, would you add a CTLA-4 or would you go on to treat with an anti-BRAF and or chemotherapy? Actually, I'll ask Pashtoon. I'll ask you first.
I think
you published on this.
It's in your slide set as well. But we had, anecdotally at least 3 in that case series, and then 4 subsequently who had Pembro, as you saw in the slide set, a third do not respond. So the question is, there is data in lung Merkel cell melanoma. You could do CTLA-4 rescue, meaning you could do ipi-nivo. So we, in this case series, showed, and several of them were BRAF V3 mutant, which is not surprising, that they had a response to checkpoint blockade. So again, this is not a trial, but it's more of an anecdotal case series. And there's a report from Dr. Berlin, as well as another report from Dr. Elderi, who has documented the CTLA-4 rescue in over now half a dozen patients combined. So just clinically a good strategy to consider in somebody who's MSI high before you go down the chemo, VEGF, or breakwater strategy. I think those would be things I would think about salvage options if they don't respond to immunotherapy.
That seems to be, anyone else have any other thoughts? But I think most people would go try another immunotherapy first and try an immunotherapy first, and then if it doesn't work, try another immunotherapy. Okay, I think there's another video.
The next case, presented by Dr. Brenner, highlights a new and exciting clinical scenario in metastatic colon cancer where long-term survival and perhaps even cure are feasible treatment goals, bringing in a whole set of new questions. I'm referring to metastatic MSI-High disease.
This is an 85-year-old female, excellent functional status. She was diagnosed with the right-sided colon cancer. She had a mismatch repair deficient right-sided colon cancer due to hypermethylation of MLH1. She was BRAF V600E positive, 8 out of 34 lymph nodes, and she was also Signatera positive. So we elected to treat her with chemotherapy. She had stage 3C disease, understanding her age of 85. She actually tolerated it extremely well. Unfortunately, within 2 months of completing therapy, she presented with left-sided flank pain, was found to have a FDG-avid mass involving the left flank and omentum. We did not biopsy it. Her Signatera turned strongly positive. And at that time, we placed her on a single-agent checkpoint inhibitor with pembrolizumab. She's had a complete clinical response to therapy. Her MRD test has become negative. And our plan is to continue the current therapy for up to 2 years if she continues to enjoy a complete response. How do we decide in the modern era in patients who have good functional status between a single checkpoint inhibitor therapy such as pembrolizumab versus the doublet of a checkpoint inhibitor therapy targeting CTLA-4?
So questions, how do you decide between single-agent pembrolizumab and nivolumab, ipilimumab for patients with newly diagnosed MSI-High metastatic colorectal cancer? How would you indirectly compare the global efficiency and tolerability of nivo-ipi to that of anti-PD-1 monotherapy in this setting? Well, I think we're getting we have trial data for that. How do you think through the use of immune checkpoint inhibitors for your patients with autoimmune disease or a history of transplant? Does your approach vary in the localized versus metastatic setting? So I think that since we've already talked about some of these already, I think the last one is interesting. And this is, we see lots of young patients, but the people who have colon cancer are often elderly and have multiple comorbidities as well. Dr. Cercek, well, how do you think about the use of immune checkpoint inhibitors, one in patients who have who do have autoimmune disease, particularly IBD, for example? Transplant's harder. I guess it depends on what was transplanted. If it's liver, you're kind of stuck, though there is some data for that. So how would you answer this question?
I think we have data from our melanoma colleagues, certainly, that, we used to be much more restrictive in terms of who we could treat or not treat. So now I think we've liberalized quite a bit, including patients with IBD, but for transplant, I would not treat a patient.
I guess if the difference is a kidney, which theoretically you can live without as opposed to liver, this has actually come up in liver transplant patients that didn't see the question before, but having reviewed the literature, there's a little bit of data. And there are also people who just don't do well and have rejection. And so you have to say that, what is it, what are the alternatives?
Can I just say, the first question, for me, it's not completely answered yet.
That's true.
Still, with low volume disease, would do single agent, and we have not seen the readout from 8HW about just first line. Yeah. It's a mix.
That's true.
The beautiful curves are actually all lines. So the first line we're still waiting for. And so I think, that remains to be determined, but maybe with large volume disease.
So I think we can compare the global efficacy because we have the curves, but as to which patients should get which, maybe is that a better way of saying it? And so, and you look at the patient and then some of the things at the end. Would that affect single versus dual checkpoint inhibitor, one of the others, I'm assuming?
Yep.
Okay. All right. And so I think we're supposed to go on to the next. Dr. Van Cutsem, who has run many of the trials having to do with actionable genomic alterations over his career. Eric?
Thank you so much. I will discuss BRAF, I will discuss HER2, and I will discuss KRAS G12C. I will not explain you the pathways again, I will just focus on some clinical data. Actually today, just prior to this session, for those who attended the colorectal cancer session, you could see an update of the Breakwater study. The Breakwater study was study first-line BRAF V600E mutant patients, 3 arms, standard chemotherapy, then an arm with FOLFOX plus cetuximab and encorafenib, and arm A was encorafenib cetuximab. Arm A was stopped a bit earlier, and then the study continued with the randomization standard versus FOLFOX cetuximab and encorafenib. These are the slides from previous meeting. Since they were under embargo, we could not put the slides of this afternoon in, but I will comment. What we have seen this afternoon is that with standard of care, with the updated data, the response rate was 37%, here it was 40%, and with the combination of FOLFOX, cetuximab, and encorafenib, it was 65.7%. There was also some data this afternoon of, in first line, encorafenib cetuximab without chemotherapy, and there the response rate was 45%. So 37, 45, 66% in this setting. So with the final data, the more mature data as they were presented here today, and actually if you look up in the New England, this is published today also in the New England Journal of Medicine, these data. Today we also saw the updated survival data. At ASCO GI and in a paper in Nature Medicine, we saw initial data on survival, very interim data. But in the updated survival data, we saw a clear difference. Median survival in the chemotherapy arm alone, in the standard arm, was 15 months, 15. In the chemotherapy, so FOLFOX, cetuximab, and encorafenib, it was 30 months. So from 15 to 30 months with a hazard ratio of 0.49. And this is quite relevant. This is not quite relevant. This is very relevant, very important. It's really practice-changing data that were presented today. There was also a clear difference and benefit in progression-free survival with a hazard ratio of 0.53. You can look up in the New England the curves of the progression-free survival. Really today, practice-changing data, that's why they're published in the New England Journal of Medicine also, on the first-line treatment of BRAF V600E mutant patients, 8 to 10% of our patients, if they are fit, standard is the Breakwater regimen. There is a cohort that will be reported that we will read out later of FOLFIRI, cetuximab, and encorafenib. There we don't have yet the data in this setting. So relevant data for this group of patients. Another group of patients are those, and they are less frequent, with HER2 positive tumors. Usually we determine that with the IHC3+ or IHC2+ followed by a positive FISH test. We've seen different agents looking in being investigated in this population. 3 to 4, 5% of patients with metastatic colorectal cancer are HER2 positive. More in the left side compared to the right side, more in RAS wild type compared to RAS mutant tumors. We've seen interesting data. Initially, the first data were from the Heracles study, lapatinib trastuzumab, showing a response rate in a non-randomized study of around 30%. And later on, we saw interesting data and 2 approvals by FDA of the regimen tucatinib plus trastuzumab. This was based on the Mountaineer study. This was a study with different cohorts. There was a cohort also with tucatinib alone. There was a cohort with tucatinib trastuzumab. Tucatinib alone was not active in these patients. These were pre-treated patients. It's not first line. So pre-treated patients were HER2 positive with the criteria that I mentioned already. But the combination of tucatinib and trastuzumab was active. You can see the waterfall plots. Response rates are in the range of around 40%, in that range. And that's the reason why, although that's not really randomized, it's randomized to tucatinib versus tucatinib trastuzumab, but not randomized against no treatment or against chemotherapy in this setting. But this is consistent, and this is an active regimen. You can see also in pre-treated patients, overall survivals, median survival of around 2 years, 24 months in this study, with some side effects, but really a manageable regimen of tucatinib trastuzumab. We have to pay attention to GI toxicity, diarrhea, fatigue is also present in some patients. And this regimen is now taken forward also in trial. Trial is not yet finished, but in the first-line setting, the Mountaineer 3 trial is in the first-line setting, a little bit the principle of the Breakwater study. So it's HER2-positive tumors who are then treated, randomized between standard of care chemotherapy with bevacizumab or with cetuximab versus chemotherapy, FOLFOX, trastuzumab, tucatinib, with as goal to demonstrate a difference in progression-free survival and other secondary endpoints. The trial is still running. In HER2-positive tumors, we have also an approval by FDA with trastuzumab deruxtecan antibody-drug conjugate. This was studied in different studies. This is a CRC01 study in which there were different cohorts, HER2 positive, and then also a cohort with low HER2 positive patients, not the standard criteria. But let's focus on the HER2 positive patients, actually 3+ or 2+ followed by a positive ISH test. There were different cohorts in this study, also in the Destiny CR01 study. And looking also, showing at the data, or looking at the data, confirmed response rate of around 45%, leading to an approval also of this agent in colorectal cancer, as well as in other cancers in this setting. Later on, there was also the Destiny CR02 study, which had 2 cohorts, different doses of trastuzumab deruxtecan, 5.4 and 6.4. But in colorectal cancer, the best dose is, and the approved dose is 5.4 milligrams per kilogram every 3 weeks, with response rates also around 40% with this agent. So really, trastuzumab tucatinib and trastuzumab deruxtecan are 2 new treatment options for patients, pre-treated patients. These data are not yet in first line, pre-treated patients with HER2 positive cancers in this setting. And finally, some data on KRAS G12C. We know that around 3 to 4% of colorectal cancer patients have a G12C. There are a lot of agents under development. We have 2 approvals by the FDA, not yet in Europe, but 2 approvals with sotorasib panitumab and adagrasib cetuximab. And let's focus just for a moment on the data. What is interesting is also that, in contrast, for instance, to lung cancer, where G12C TKI, sotorasib alone, for instance, is active, in colorectal cancer, we have to combine it. As with the BRAF tumors, we combine also encorafenib cetuximab. Here we combine G12C TKI with panitumab or cetuximab. These are the data from Codebreak 300 study of sotorasib panitumab, showing clear activity also in this study with response rates with around 30% in this group of patients with the G12C mutation, with adagrasib cetuximab also Ronnie Jaeger published data response rates around 34%, so 1 out of 3 of the patients with an objective response, but more than 80% of patients with a disease control. This is not randomized. We're waiting for the randomized data in second line of G12C mutant patients of chemotherapy versus adagrasib cetuximab. These data, we're expecting them in the near future in this setting. And recently we also saw, as you know, there is a whole generation, a whole list of KRAS G12C inhibitors. We've seen, for instance, these data being published, cetuximab in combination with divarasib, which is a new generation TKI against G12C. This is a phase 1b trial, and it's always dangerous to compare that with the other data, but at least of the new generation data, they look favorable compared to the sotorasib panitumab or adagrasib cetuximab. So there is more to come, and maybe more active regimens are coming. This afternoon, while I was on the way to this symposium, there was in the session, in the colorectal cancer session, 3 abstracts in the oral session on different combinations, early data, with some new second generation TKIs, such as olomorasib, and then also with what is the next step is also taking these TKIs forward in combination with an EGFR antibody and in combination with chemotherapy. As you can see here, a study with FOLFOX at the bottom of the slide, a study with FOLFIRI, sotorasib, and panitumab in this setting. Early data, phase 1 data, but at least the conclusions of these presentations is that there are new generation TKIs which are coming through, possibly more active than the first generation. And then also we are moving towards the field of combining this with chemotherapy also in this setting, a little bit like the story that I explained to you in BRAF mutant patients and in HER2 positive patients. So colorectal cancer, we are the molecular subgroups. It's evident that we do NGS in our patients. Molecular subgroups are important. On the left side, you can see those subtypes which have validated and or approved treatment options for these subtypes. But for the other subtypes, such as RAT, ALK fusions, and so on, we have at least anecdotal reports also that there may be in this group of patients activity of some of the new agents. Thank you.
Thank you, Eric. Now we have two cases.
The next 2 cases focus on the rapidly evolving management of BRAF V600E mutant colorectal cancer, and specifically the use of targeted treatment in older patients who may already be burdened with significant comorbidities, such as a case from Dr. Rudolph.
She's 89-year-old. She was very active. She was volunteering in a local hospital until 2021, when unfortunately she was diagnosed with COVID pneumonia and has since required to be on continuous oxygen at 2 liters. Outside of requiring oxygen, she's actually fairly functional. She lives alone and she's able to take care of herself and has excellent family support. Her only other comorbidity is hypertension and atrial fibrillation.
I see that she's now progressing on FOLFOX-Bev. What's the plan?
She would love to continue on with treatment. Could she be switched to treatment with encorafenib along with panitumumab, given her BRAF positive disease?
Yeah, it's enough to think about a frail 89-year-old woman, but when you add one who's also on oxygen, that must be particularly challenging.
I like to give people the benefit of the doubt as far as treatment and back off if they start doing poorly. What I always tell people is, let's give it a try with a smaller dose or whatever, reduced frequency. And if you can't do it, we call it quits, but you got to at least try.
The other related case is from Dr. Giffey, one of many patients who received targeted BRAF therapy where treatment tolerance is a critical issue, in this case second line, but now a consideration as upfront treatment for metastatic disease. Any questions about using encorafenib and cetuximab?
Yes, I would love to hear tricks beyond the usual EGFR rash. So all of the topicals, oral doxycycline, does decreasing the frequency help? Are we compromising the length of remission if we decrease the frequency? She had a pretty significant rash from both, actually. We held one to figure out which drug was causing the rash, and she actually had a very different looking rash from encorafenib, much finer than the pustular rash from cetuximab. So any tricks with the rash would be helpful. I'm excited to use this in first line in my next BRAF mutated patient. And then the last question I had is, have investigators ever used a different BRAF inhibitor off label after progression on encorafenib? By the time she progresses, her tumor won't have seen a BRAF inhibitor for a couple years. So I was wondering if maybe she would respond again if I indeed find that she still has a BRAF mutation.
So questions, what would you recommend next for Dr. Rudolph's 89-year-old patient? Would you restart FOLFOX bevacizumab at a reduced dose? Would you switch to capecitabine bevacizumab, switch to encorafenib and an anti-EGFR antibody given her BRAF status? Maybe we should answer that first. Dr. Van Cutsem, how do you feel? I have to remember now back to the case, so please forgive me. This was an elderly woman who had BRAF, who had progressed on chemotherapy. I think that's kind of more straightforward. What would you do with someone like that?
Yeah, I would of course discuss with the patient and see and judge the general condition in view of her almost 90 years old. But if she was eligible for treatment, I would go for encorafenib cetuximab in this patient. She was BRAF V600E mutant. I think this is still less toxic than chemotherapy doublet, at least in this patient population.
And one nuance, if I could add, is we're all used to kind of like anti-EGFR rash by giving it to our patients with chemo. The BRAF inhibition overcomes some of the EGFR rash. So the toxicity of the rash is actually counterintuitively less with the RAF combination, so much so there's actually now a BRAF cream being studied in trial to overcome the EGFR rash. So the rash of patients with BRAF on the encorafenib with cetuximab or panitumumab is less severe than what you and I are used to by when we give chemo EGFR alone. So it is tolerable.
Yeah, it's counterintuitive, and in the data that were presented today, this is not really an issue anymore in first line. We treat them like we treat EGFR-associated rash, but it's not a real issue. It's not a reason.
You probably know this data better than being part of it than anyone, but I thought that, back to what you were saying, is that the percentage of people who stopped, because now they're mostly not 89, but the percentage of people who stopped, because of toxicity was very small.
That's correct. Very, very rarely patients stop because of skin toxicity. Of course, some patients who may stop also there is FOLFOX in this regimen, also in the breakwater. But if you look at encorafenib cetuximab alone, without chemotherapy in elderly patients, there are very few patients who have to stop the treatment because of side effects.
Okay, I think we need to go on to the next case.
Our final case focuses on a topic RTP is addressing this coming Sunday night at this time, HER2-positive gastrointestinal cancers. And as a prelude to this symposium, Dr. Divers presents yet another elderly patient who in this case presented with extensive metastatic colon cancer.
This is a very sweet lady who is 84 at presentation with a very large rectosigmoid cancer and presented with pain, probably due to local invasion and anemia and hematochezia. Her initial endoscopy and biopsy showed an adenocarcinoma of rectal origin, which was microsatellite stable and RAS and RAF wild type. She had extensive liver metastases at presentation and, diffuse metastases throughout her liver, but had somehow maintained her liver function. And the HER2 in her case, was notably amplified. She was treated with dose-attenuated oxaliplatin 5-FU and bevacizumab. Notably, her initial CEA was like 4,000 at presentation. Her CEA declined to essentially less than 10. She had an amazing response with subsequent imaging showing complete resolution of hypermetabolic uptake in the lesions in her liver and in her rectum. And so I believe that the HER2 acting agents are typically reserved for second-line therapy in this colorectal patients. But what would anyone's thoughts be, I think, for therapy going forward in this patient? How does the HER2 factor into that equation? What's the role of tucatinib and trastuzumab or TDXD in that space?
So questions, what would you recommend next for this woman with HER2 amplified but IHC 2+ disease? In which line of therapy do you typically recommend HER2 targeted therapy for your patients with HER2 positive metastatic colorectal cancer? Would you administer HER2 targeted therapy for a patient with previously untreated HER2 positive metastatic colorectal cancer in any situations? How do you choose between TDXD and tucatinib trastuzumab for your patients with HER2 positive metastatic colorectal cancer? Are there any patients for whom you prefer one regimen over another based on HER2 expression levels, RAS mutation status, or site of metastases? So Eric, since you've been working on this, there are a number of things that are brought up to tee up for you.
A lot of questions. We don't have so much time, but the short answer is yes, I would recommend that this patient HER2-directed therapy. This is an elderly woman. If the tumor was RAS wild type, then I would probably go for tucatinib trastuzumab. In the tucatinib data trial, an inclusion criteria was that the tumor was RAS wild type. Trastuzumab deruxtecan can also be in the occasional RAS mutant patient. That can be an option, but the patient was a bit older, so although we don't have data on sequencing, would probably go rather in this elderly woman for trastuzumab tucatinib.
Now, in breast cancer, they seem to have no level of HER2 that seems to not respond to TDXD. On the other hand, it's really quite different, as you presented in your talk about the differences, and because this patient, who was presented, is only IHC 2+, and I really was disappointed by the data in the 2+. Do you have any thoughts about why, once again, colorectal cancer is different?
We don't have a good explanation for that reason, but in HER2 2+, IHC 2+, but with a positive ISH test, like here in this case, there was some activity in this setting.
It was mostly stable
it's
disease,
different compared to breast cancer, where you may have also in IHC 1+ patients some activity in this setting.
Dr. Cercek, do you have thoughts about how one versus the other? How you choose the patients clinically, and then I think I'm going to have to get going.
Sure.
Well, you have one minute, sorry.
Sure. It's similar to what Dr. Van Cutsem outlined. I think it depends on the patient's overall performance status, and if the tumor is RAS wild type, I would choose trastuzumab and tucatinib before TDXD, but we don't have data on sequencing.
And I think also, like I have two patients I'm treating at the same time. One has multiple lung mets and has a multiple radiation, and he's on tucatinib and trastuzumab. Another person who has an ileostomy and is always on the verge of being dehydrated, and that person's on TDXD. So with that, I just want to thank the contributing general medical oncologists, really, who obviously had a lot of thought and had very good questions. I'd also like to thank really, you have a wonderful group here, the people who really are pushing the trials forward and pushing knowledge forward. And I'd also like to thank you for spending a late evening with us. Thank you very much.